Hello, my name is Anil Devan. I'm Professor of Children's Liver Disease at King's College Hospital, London. The purpose of this film is to provide you with as much information as we possibly can about liver transplantation, even before you come for an assessment.
Hi, my name's Jill Wilson. I'm the Paediatric Liver Transplant Coordinator here at King's. This is my colleague Liz Holborn. She's Liver Transplant Educator and we're part of the Liver Transplant team.
This series of short films is designed to introduce you to the King's Liver Unit. The films will provide you with the information I'm sure will be of great help in understanding the need for transplantation, the process we will work through together, and the long-term effects of a liver transplant.
To go through from the very beginning of first finding out that your child needs a transplant is quite challenging, but I personally cope better if I know what's coming next, and information is the key to that, and from the medical profession to have the right information is that makes it so much easier.
We suggest that you watch each part of these films separately and discuss any issues that arise within your family and make notes of any questions.
Many of the issues covered in these films will be discussed with you directly in greater detail, but these films will be a great starting point for familiarising yourself with the team, and we can then work together to assess the need for liver transplantation.
King's College Hospital performed its first paediatric liver transplant in 1989. Since then, the King's Liver Unit has carried out over 500 transplants and is currently responsible for about 50% of all paediatric liver transplants in the UK.
King's treats between 40 and 50 children each year with liver transplantation. Our youngest child was 5 days old at the time of her transplant. Our smallest weighed 2 kilos. That's about the weight of a bag of sugar. The transplant team consists of a large number of experienced and specialist individuals. Together they represent the best possible care for your child.
The liver is a vital organ. Apart from the brain, it is the most complex organ of the body. It has as many as 500 functions, all of which are essential to life. There are many reasons why a child may require a liver transplant. You will have the opportunity to discuss your child's individual case when you come in for assessment. The liver is the largest gland and the largest solid organ in the body. It is just under your ribs on the right side of the body. Each year, 80 to 90 children will receive a liver transplant in the UK, with survival rates being as high as 95% after 1 year and 86% after 5 years. However, as each child is individual, these figures serve only as an overall guide. There is a shortage of organs for transplantation, and unfortunately, some children still die whilst on the waiting list. However, a variety of techniques have been developed which can use this limited supply of organs to maximum effect. The liver is made up of 8 segments, each with its own blood supply and bile drainage. This means that it is possible to use just part of the liver for transplantation. Sometimes, the donor liver is too large for the child. The surgeon reduces the size of the liver by removing some segments and transplanting the remainder. The new piece of liver grows as the child grows. From this technique evolved split liver transplantation, where the right lobe is transplanted into an adult or larger child, and the left lateral segment, about a quarter of the liver, is transplanted into a younger child. King's also offers pioneering techniques such as living-related transplantation, where a living person donates a part of their liver, and auxiliary transplantation, where part of a donor liver is transplanted alongside the child's own liver. Where an available liver is of an appropriate size for the child, the whole liver may be used. King's has also pioneered hepatocyte transplantation, or the transplantation of liver cells. Although still experimental, this is now possible for children who, with the exception of missing one vital enzyme or function, have a healthy liver. Hepatocyte transplantation can also be used to treat acute liver failure as a bridge to future transplantation. In all cases, the donor has to be carefully tested to see if they are suitable, since this is not always the case. The King's Liver Unit's aim in offering the most appropriate transplant is to provide your child with an improved quality of life, and for many children, it is life-saving. Liver transplantation has revolutionized the outlook for children and young people with liver disease. But it is a major undertaking for all concerned, and much is involved for patients and their families as they move through the many stages. Liver transplantation is a lifelong commitment, requiring daily medications, regular clinic appointments, and the need for a healthy lifestyle.
Family members can feel isolated and helpless at this traumatic time, so a support network is a vital part of the Liver Unit service.
When I wanted to get some more information, when I was things that were worrying me, that I needed to speak to somebody, I had a contact point in King's to be able to ring a role that's called transplant coordinator, which at King's is done by a very lovely lady. And I could always phone her. She always gave me time. She was always there. If she didn't know answers, which generally speaking she did, she found them out and she rang me back very promptly, very swiftly. Replies were always there. And that made a big difference to know that I could ring somebody and they would listen and that they were there.
Although the transplant coordinator, educator or nurse specialist will be the first port of call, certainly over the telephone, this process utilizes the expertise of the whole King's Liver Unit team, both medically as well as providing practical and emotional support whenever needed.
Of course, there's no better support for you than your family, so sharing information and communicating your feelings will be a great help. It is well known that children cope much better if they have some knowledge of what is to happen, and so depending on the age, development and understanding of your child, discussion amongst the whole of a well-informed family can be a great help.
The assessment process itself can take a day or two, depending on the circumstances, and you may be asked to stay in hospital. However, we do endeavour to have the transplant assessment done in one day in the daycare unit. It's important to say here that in our experience it's helpful to bring a partner or relative or friend for support.
Yes, I had my mum there at the time, my mum and dad, so my mum was a big rock. You do need someone, definitely, without doubt.
To have somebody with you who is just slightly emotionally removed from the situation means they have a more objective view of what's going on and can absorb the information better, can remember it, can possibly remember some of the questions that you wanted to ask prior to going there, which again, writing down the questions you want to, when you're sitting at home and you think, I want to know this, I want to know that, it really is a good idea to write the questions down and take the piece of paper along with you.
During this time, you will have the opportunity to meet the team involved in the transplant programme, and where possible, you may also meet families who have gone through similar experiences.
Try and talk to as many parents as possible, as well as doctors and nurses. They will reassure your parents as well as the professionals.
I desperately wanted to talk to somebody who had been through the same situation, and luckily I was given a phone number of another family who I never met but I spoke to on the phone, and that was very, very helpful.
You will also be shown the wards and the facilities that are used before and after the transplant, and we will discuss any further support which may help in the care of you and your child.
The purpose of the assessment is to discuss the management of their liver disease, the risks and benefits of transplant, the decisions that need to be made by everyone involved, and to explore the alternatives available. To gather the information needed to form the complete picture of your child's condition, the team will carry out a series of tests. As each child is unique, the tests required vary accordingly. These tests will include blood tests to confirm the child's blood group, to show how the liver and other organs are functioning, to find out which viruses and infections your child has come into contact with, and to see if any further vaccinations are needed. Screening for HIV, hepatitis B and C is also required. Other tests may include an ultrasound scan of the abdomen, a procedure which creates a picture of your child's liver and the surrounding organs. It will also show how well the blood is flowing into and out of the liver. An anaesthetic assessment will be carried out to find out in advance any specific help your child may need during the transplant operation. The echocardiogram, an ultrasound scan which gives a picture of the inside of the heart, may be carried out. An electrocardiograph (ECG) test will check how well the heart is working. The glomerular filtration rate (GFR) test will check how well the kidneys are working. Lung function tests may be done to see how well oxygen is carried by the blood. X-rays of the chest and bones will be taken. A developmental assessment will be undertaken to see how your child's liver disease has affected their general progress. A nutritional and growth assessment will also be carried out. A dental assessment will be undertaken and treatment and advice given. Tooth decay increases the risk of infection before and after transplant. Careful attention to teeth cleaning helps to reduce the risk of infection.
It was very well explained. There were a lot of tests that she had to do, but each one was explained why and what they were going to gain out of it. Unfortunately, we didn't get a decision at the end of the 5 days as to what the outcome of the assessment was, and we had to go home and wait for the decision. And that, again, was very, very difficult. There's an enormous amount of waiting involved in the transplant process.
The team will discuss with you the results of the tests and the suitability of your child for liver transplantation. Making decisions can be very difficult, and many parents find it useful to reflect and discuss, together with their families, the issues in more depth. In most cases, transplantation is only made possible by the generosity of relatives giving consent for the donation of their loved one's organs at the time of their death.
Not every person that dies can become an organ donor, and many potential donors are being missed due to lack of knowledge and understanding about transplantation.
This highlights the importance of donor cards. If it were the norm that the general public carried donor cards, the availability of donor organs would be increased, and consequently, the waiting time greatly decreased. In all cases, stringent tests are carried out to establish the suitability of the organ or part of the organ for transplant. There is, however, no absolute guarantee that the donor liver will function properly, or that illness or infection will not be passed on to the recipient. Once the decision has been made that transplantation is appropriate, your child's name will be placed on the waiting list. It is important that normal family life continues as much as is possible. The transplant coordinator will take all your contact numbers from you, so that you don't have to have someone waiting constantly by a phone. It is obviously very important that the liver unit team are informed of any changes to your contact numbers.
The transplant coordinators will be relying on you to keep them up to date with any changes in your child's health.
The transplant coordinators must be informed of any admissions to hospital, any new infections, temperatures or changes in treatment, for example, antibiotics. During the waiting time, ensure you are fully prepared to go straight to the hospital as soon as the call comes. This includes arranging care of any other children, dependents and pets.
It's impossible to predict how long your child will have to wait for a liver, and sadly some children do die whilst waiting on the list.
However, your child will be seen regularly at the transplant centre or your local hospital in order to monitor their health during this waiting time. When a suitable liver becomes available for your child, you will be contacted by one of the transplant coordinators.
We appreciate that this waiting period can be a very anxious time for you and your family. Don't forget, there is always someone available at the transplant unit to discuss any problems you may have.
When you arrive on the ward, your child will have tests to check their present condition. The average time for a liver transplant is about 6 hours. That's 1 hour for the anaesthetic and then 5 hours for the surgery itself. You will be kept informed of how the operation is proceeding, but you should not be unduly alarmed if the operation goes on for longer.
During the operation, when your child's actually in theatre, it's essential to have somebody with you, somebody who knows you, somebody who knows how you're going to react, somebody who knows what you need without you really needing to tell them. They were excellent. They communicated with us all the way through the operation. The operation was actually quicker than we anticipated and took 5.5 hours. We had updates all the way through saying The old liver's been taken out, she's doing fine, and then another hour later the new liver's in, that's doing very well, and then finally a phone call to say it's all done, she's absolutely fine, she's coming back up to intensive care. And then we were able to see her, so we were very well informed the whole way through the operation.
You may experience a range of emotions, from guilt to happiness that your child has been given a new liver. Your child will go from the theatre to the intensive care unit, often shortened to ICU, ITU or PICU. Your child will usually appear deeply asleep, as they will have been given continuous medication through a drip to keep them relaxed, prevent pain and reduce movement, and thereby allow complete rest. Intensive care units can be very daunting places because there is a lot of highly technical equipment in use. They have sensitive alarms to alert staff, but it is an environment where each patient can be cared for on a one-to-one basis and closely monitored during the initial period of recovery. The equipment used depends on your child's needs, but please do not hesitate to ask if you do not understand what equipment is being used for or want to know why the alarms are sounding. Since your child is heavily sedated, a ventilator is used to help with their breathing. Your child will have a tube in their nose or mouth which is attached to the ventilator. During this time, your child may still recognize familiar voices, so do talk to them if you feel able. The length of stay in intensive care will vary for each patient, but is often only 24 to 72 hours. Once intensive care is no longer required, your child will return to the ward. Close observation will continue, and the drips and drains will be removed as your child's condition improves. Children of all ages like to hear from friends and relatives. A letter, picture, or tape can help remind them of home and help with recovery. At this stage, your child has been through a lot, and it is not unusual for your child to have times when they are irritable or upset. You may experience similar feelings. There are a number of people on the team who are there to help. Please ask the nurse caring for your child if you would like to speak to somebody.
As soon as your child is well enough, it may be possible to go out for a few hours a day or maybe overnight in preparation for discharge home.
There is usually accommodation available, either in our Ronald McDonald House or our Rhys Daniels self-contained flats. The idea is to help families to return back to a more normal family life, with the essential backup of the hospital close by to give you confidence.
At some point after the transplant, you may wish to write to the donor family. This is usually greatly appreciated and reinforces to the donor family that they made the right decision.
It's important to mention potential complications of liver transplantation that may occur both short and long term. Most of these complications can be managed successfully. However, sadly, some children may die or require another transplant.
Primary non-function. This is when the new liver does not work. It is very rare, but may happen in the first few hours or days after transplantation, and will require emergency relisting for another liver. Hepatic artery thrombosis. This is uncommon, but can happen more often in infants and small children due to the size of blood vessels. It may result in the need for further surgery, or, if irreversible liver damage has occurred, emergency relisting for retransplant. Bleeding. This is uncommon, but should a bleed occur, this may require going back to theatre for further surgery. Rejection. This is a normal body process, and more common in the first 5 to 10 days after transplantation. It can, however, occur at any time, though more frequent in the first 12 months. Rejection is usually treatable and reversible, but may become a long-term problem for a few children. Chest problems. For example, pleural effusions or fluid in the chest are common after transplant, but only problematic if they result in difficulty in breathing. The physiotherapist will see your child to help and encourage deep breathing exercises and coughing. Following transplantation, immunosuppressant drugs are needed for life to help prevent rejection of the new liver. However, this means that the body's own immune system is not as good at fighting disease and infection. As a result, Some children may have a degree of kidney impairment following transplantation. In order to monitor this, annual GFR studies are carried out, and the medicines may be modified to reduce these side effects. EBV, or Epstein-Barr virus, commonly known as glandular fever, is a common virus that many people come into contact with and causes flu-like symptoms and a sore throat. However, if a child becomes infected with EBV for the first time after transplant, or if the virus reactivates at this time, it can cause overproduction of certain types of white blood cells, called lymphocytes, and enlargement of some of the lymph nodes or glands. This is known as post-transplant lymphoproliferative disorder, PTLD. In rare cases, this condition has the potential to turn into a form of cancer called lymphoma. After going home, your child will be closely monitored, will have frequent blood tests, and will be seen by the liver team at regular intervals. In addition, your child will be on the Shared Care programme with King's. This is run by clinical nurse specialists, so that as few as possible visits into London are made.
After the transplant, it takes time for the child and the family to get back to normal. Discipline, behaviour, eating patterns, all of these things take time to settle. I think it requires great patience on the part of parents and the families to allow time for things to settle down and for things to gradually get back to normal. It's important, though, to establish a routine, a pattern of life that a child can get back to some form of normality after such a difficult time. There will be opportunities to discuss these issues at the hospital appointments.
Before leaving hospital, you will be advised about the medicines your child will take after going home. Some of these medicines will be taken for life. The nursing team, along with the transplant coordinator and educator, will help you to establish a routine that will ensure that progress is monitored well and that the medicines are most effective in aiding your child's recovery.
When your child is discharged from hospital, you very quickly fall into a routine of what needs to be done, of when to take medication. The immunosuppressants do have to be taken in a fairly rigid time scale, not exactly to the minute, but you do have to take them fairly close to the same time every day, twice a day. We now very easily, if we're going out in the evening, my daughter says, "Oh, I better take my medication with me. Are we going to be out after 8:30? If so, shall I take my medicine with me?"
There is a need to strike a balance between allowing your child to lead a normal life and monitoring the recovery process.
Family is just like a normal family, apart from Sam take medicine and get on with life. You get treated exactly the same as the other children, and apart from the odd treats he get with an extra anniversary of his transplant, so you think it's an extra birthday, but he lead a very normal life, very normal.
Yeah, your children can have a normal life afterwards. It's a bit of medication. It really goes into a routine. And just enjoy life with your children and take it a day at a time.
Establishing routine is the key, and it will become second nature in time. Your family GP will be fully informed about your child's transplant, but it is important that you contact him or her within the first week of returning home, as he or she will be one of the primary contacts should your child become unwell. You should never give your child over-the-counter medicines without asking a doctor or pharmacist. This is to make sure that you won't be giving your child anything that will conflict with the post-transplant medication. If your child is admitted to hospital at any time after the transplant, even years later, please contact the transplant unit, even if the problem is not related to your child's liver. If vaccinations are required, their suitability needs to be checked before being administered. Care should still be taken in avoiding infections and maintaining a high level of hygiene, and you should continue to monitor your child's general health.
The transplant team will discuss with you how best to avoid infections, what changes in your child's health to look out for, and advise you on the best course of action to take.
We know when something is wrong. We will get in touch with the Children's Hospital if we know that temperature goes over a certain level. Of course you're worried, but you're worried with another child as well. So I don't think we have to be extra precautious. Precautious, I think is the word, yeah.
I think on the whole it is possible to give your child a near normal life when they've had a transplant. Near normal includes going to hospital for checkups, going to clinic for blood tests, and it's not normal in the way that their friends are at school, because their friends don't have to do that. But they do. My daughter is at present skiing, and what's more energetic and slightly dangerous than skiing, but she's out there, and yes, she just gets on with life, just gets on with it.
As your child grows older and moves towards puberty, specific advice on issues such as sexual health will need to be addressed. It will still be necessary for your child to be seen by the liver team from time to time, but as their condition stabilises, visits to hospital and blood tests will become much less often.
When I look back over liver transplantation over the last 20 years at King's, I think the key part of our success has been the partnership that is established between our staff, the child, the parents, and the extended family. This partnership has allowed us to be successful and to produce excellent results, both in the short term, but also in the longer term, and that remains our goal.
Although there will be good days and bad, you are not making this journey alone, and the King's Liver Unit will always be at your disposal.
So we really never look back. She's actually healthier than the rest of the kids in the street. And I mean, it's just a miracle baby. She's fantastic, little mischief, knows exactly how to wrap anybody around their finger, including some of the nurses here and that had been seeing her before in King's as well. And it's just superb.
See, I don't wrap Sam up in cotton wool because that is who he is. You know, he's had his transplant, he's normal to us. He's always laughing and outgoing. He's not within child, so he's always laughing now.
I hope you found the information in this DVD helpful. I would like to take this opportunity to thank the sponsors of this project, which are Estella's Foundation and Sunday People newspaper.